of you.
Oma.
Good evening to all of you, sir.
Good evening,
Aparna. Welcome, Dr. Aparna.
Thank you, sir.
HOD Nilofar.
Ma, I think Divya, I think shall we start?
Yeah.
Okay, right, I'm start.
Okay, sir. Good evening, everyone. Respected all the dignitaries present today. It's a privilege to me to present this case in front of all of you. I thank Dr. Jane George, sir, for helping me out with this presentation. A 12-year-old female child, resident of Nizamabad, born out of third-degree consanguineous marriage, was brought by her father, reliable informant, with chief complaints of fever since 1 month, weakness of lower limbs since 20 days, weakness of upper limbs since 15 days, pain and pricking sensation in the lower limbs since 15 days. History of present illness. 1 month ago, child developed fever, sudden in onset, high grade, intermittent, associated with chills, subsiding with medication. Fever continued for 3 to 4 weeks. Child had loose stools, watery, foul smelling, containing mucus, not blood stain, 7 to 8 episodes per day, subsided after 1 week with medications. History of present illness continuation. After 10 days of illness, child complained of weakness of lower limbs. She had difficulty in getting up from sitting position. She was able to walk with splints in both the legs. Gradually, child was not able to stand. After 2 to 3 days, she was not able to roll over in bed, unable to get up from supine position. Complaining of weakness of upper limbs in 15 days. Initially noticed as difficulty in holding objects, followed by difficulty in lifting arm above the head. Weakness in both upper limbs started at the same time. Child also complained of pain and pricking sensation in both lower limbs in 15 days. Initially at the soles, gradually progressed up to the hips. It was exacerbated on touch. No history of difficulty in breathing or swallowing, no history of diurnal variation of weakness, no history suggestive of bowel or bladder involvement, no history of altered sensorium or seizures, no history suggestive of involuntary movements, no history of altered sense of smell, no history of blurring of vision, photophobia, double vision, no history of drooping of eyelids, restricted eyeball movements, no history of difficulty in chewing or mixing food in mouth, no history of deviation of angle of mouth or difficulty in closing eyes. No history of nasal regurgitation, choking, or change in voice. No history of neck stiffness. No history of recent vaccination or IM injections. No history of recent insect bites. No history of fall or trauma. No history of abdominal pain, photosensitivity, altered urine color. No history of pica, herbal drug intake. No history of recurrent oral or genital ulcers. Past history. At 7 years of age, child developed high-grade fever followed by weakness of lower limbs and abnormal gait was noted. Child was taken to the hospital where she was advised splints and physiotherapy. Child was able to walk, go to school and perform her daily activities. Antenatal history. Registered at government hospital, taken 2 doses of TT and iron folic acid prophylaxis. Fetal movements were well perceived. No history suggestive of any obstetric or medical illness in all 3 trimesters. Birth history, term delivery, term gestation, normal vaginal delivery, cried immediately at birth, birth weight 2.5 kgs, no history of any NICU admissions. Developmental history, all milestones were attained appropriate to age without any delay. Child studies in 6th standard with average school performance. Nutritional history, there's a calorie deficit of 500 kilocalorie and protein deficits of 10 gram. Immunized up to 5 years of age, BCG scar present. Family history, third degree consanguineous marriage, no history of similar complaints in sibling or other family members. Child belongs to class 4 as per modified Kupus-Formey scale. Because
can you stop sharing?
Yes.
For examination, I think before that we should go for the history part.
Okay.
I think Dr. Divya is very fast in providing the information. That's good. But you know, sometimes it may be difficult for the persons to follow. So anyway, can you stop sharing?
Yes, sir.
I hope that are there any other students on the screen? Dr. Divya, your colleagues are there? Anybody?
Yes, sir. They're there. Yes, sir. They are there, sir.
Because I think it may be difficult for me to locate them.
Yes, sir. They're there, sir.
You
I
can see at RVM, you can see iPhones, all iPhones are PGs, most of them, sir.
Okay, okay. But I think they are smart enough to keep this their naming as iPhone rather than name of the person. But no problem.
Ask them to type the response, sir. It is difficult
Yeah.
for them to ask, I think. Ask them to type the response.
And I request them that please keep your video on so that we can have the interactions, we can see each other, and all of you know that eye contact is the good for all of us. I think rather than Divya, I hope that other students should respond. Anybody can voluntarily start. As Dr. Yashwant Rao said that all names with iPhone, they are the students. So I wish that voluntarily, if somebody is ready, that's good. And I think that is the first lesson which all of us should start. That participation in the discussion. Maybe even whatever you know,
Sir, me the
without
mute
any
and-
hesitation.
Oh, okay.
Right, Amma, right. I request the postgraduates, any one of you PGs or even SRs, they can participate in with this history. What is your impression on the patient? You have been given history, and I think this history, what is your tentative impression? Any postgraduate or even the SRs?
Sir, we can call upon the names if we know the postgraduate, I think, sir. Sorry to interrupt. Dr. Nikita.
Yeah.
Dr. Nikita, you can unmute and answer.
Yeah, I think I request you and the other teachers, those who are knowing their students, that,
We'll call them.
you may encourage them.
Yeah. Senior PG Nikita, you start.
Yes, I think just if somebody starts, then I know that others will join.
Yes.
Always,
Sir, good
always
evening. Can I ask one question, sir? I'm Dr.
Yes,
Good
Yes.
evening, sir.
Hello.
yes, please.
As a presenter, what is dissociative sensory loss? Hello, the presenter can answer. Hello, you're able to hear me? Hello.
Yeah, we can hear you, sir.
Yeah.
Divya,
Sir, I'm
can
asking
you
what is
summarize the
dissociative
history?
sensory-
Once?
Sir,
Can you summarize the
dissociative
history?
sensory-
Divya, can you summarize the history, please?
Yes, sir. Yes. A 12-year-old female child, sir, came with complaints of weakness of lower limbs, fever since 1 month, sir. After 1 month of fever started for 1 month, sir. After that, 5 days later, she developed loose stools, sir. Loose stools for 1 week, which subsided with medication. 10 days later, child developed weakness of lower limbs, sir, which gradually progressed to involve even upper limbs. Child also had involvement of pricking and pain sensations in the lower limbs, sir, as of now. And the child also had significant past history, sir. At 7 years of age, child had similar complaints, fever, followed by progressive weakness, for which the child was taken to nearby hospital, and child was advised on splints, sir. After which the child started walking using them. Again, the child developed similar complaints now, sir.
Yeah, sir. Sir wants to ask. Archana Swami has asked some question.
So 1 second, sir. Doctor, what is dissociative sensory loss? Presenter. Actually, you have posterior sensations, posterior column sensations like vibrations. And lateral spinothalamic pain and temperature. No, suppose the lesion is in spinothalamic tract, the posterior vibrations will be present, but pain and temperature will be lost. In spinothalamic lesions, the vibrations, the posterior column lesions, vibrations will be lost and pain and temperature will be present. So this history you have to ask. So you told pins and needles, no, that is positive signs. You have to say about negative signs also. Loss of sensations, loss of vibrations. So you told about motor weakness, that's okay. About sensory, I want some more detail. Because whether it is a transaction missection of cord or only the motor part is involved, that we should know. And any neurological insult, three things to be noted: onset and progression. Onset is acute or just, for example, thrombosis, hemorrhage, and embolism. Thrombosis will be slowly evolving. Hemorrhage and embolism, sudden involvement will be present. And from the onset of weakness, you have to say whether it is improving, static, or deteriorating. If it is improving, it should be THE, thrombosis, hemorrhage, or embolism. If it is static, it is cerebral palsy. If it is deteriorating, it is degenerative disorders. So any neurological weakness, you just you have to say these details. Also, sensory system, positive signs, pins and needles; negative signs, loss of vibration, loss of pain, or those things. Okay, I felt you have missed those things. In next time when you present, you concentrate on these things. Okay.
Okay, sure, sir. Sure,
Okay.
sir. Thank you.
Thank you.
I think, Dr. Divya, my question to you, you said that this fever is since 1 month. Still the child is running the fever?
Yes, sir. After admission, child had continuous fever spikes, sir. It
Okay.
initially was high grade, sir. When we were coming to time of the discharge, fever was coming towards lower grade, sir. But initially, child had continuous high grade fever, sir.
No, my point is, since 1 month illness is there, and you said the first problem was fever. Whether
Yes,
the fever is still there or already child is afebrile, what is the present status?
At admission, child came to us at 20 days of admission, sir. The child, after admission, the child was with us for almost 2 months, sir. In that 2 months, the first month, child had continuous fever, high grade fever.
Okay, okay. So the child had the fever, and along with the fever, child developed the weaknesses. Initially, lower limbs, as you said, progress to the upper limbs, right? Yes. So the point is, what will be your thought process? What is the likely problem? Number one, always try to think, is it really the neurological problem or something else? And first, then suppose if it is neurological, then where is the anatomy? And once you try to locate the anatomy, what is the likely pathology? And with that pathology, what is the possible etiology? If from the history we are able to think, which may not be possible every time. I think this should be our thought process. Now coming back to what is your response, whether is it neurological issue or something else?
Sir, we neurological, sir. Initially, we thought of muscular or neurological, sir. But initially, it started distally, sir. Muscular, generally, we tend to start proximally, but this started distally, sir. First, her issue started gripping slippers. Later, it progressed to proximal, sir. So, and there was in general examination, I'll come to those points, sir. On inspection, there are few findings like atrophy and all, which are
Dr. Divya, I think this is the point which always I try to make out. Don't jump to this neurological or something. I will say, suppose simply, I will say it's a periodic paralysis. And with the risk, even you are giving this some past history also. Similar some issue. Still, we don't know the details of the past history, but suppose for a while, if we consider that it was also the similar issue, then I will say simply it's a periodic paralysis to me. Why it is maybe the hypokalemia every time developing. That can also come in this way. So
yes, sir.
What is your point?
Sir, with this history, we can even consider periodic paralysis. Familial periodic paralysis, one of them. With this start history.
Yeah, always, not only for the students for examination, but our practice also. Once the patient enters, we don't know the cause.
Yeah.
Probably from some information we are trying to derive. Already you have come with a prepared, or I will say diagnose, or maybe the workup case, so you may be clear. But once the patient enters your room on day 1, Probably the clinician does not know anything. Not many things will come to his mind. And then gradually we are trying to locate that how we should proceed further. So let us think in this way, in that direction. So my point is, probably I will say, suppose for the sake of examination or in some examiner ask you that simply it looks me the periodic paralysis. So how is the question of neurological problem? How will you explain? Both the ways. Always, I think even other students will participate. That suppose, would you like to consider periodic paralysis? If yes, what are the favoring or supporting points? Suppose if you say it does not favor, then what is your probable explanation for not consideration? In the always, I will say this is the way that how we can go further in our thought process and try to locate. So let's say,
sir, good evening, sir.
Yes.
Sorry for interruption, sir.
Yes,
Child presented actually with a fever, then loose motions. After 10 days of subsidence of the loose motions, child started having weakness of the lower limbs, sir. That is gradually progressive as per our history. Weakness suddenly not started suddenly in all the 4 limbs, sir. It is actually started in the lower limbs. Over 5 days, it is a progress to upper limbs. So in that way, it is like after 10 days interval of loose motions and gradually progressive nature, I thought probably hypokalemic periodic paralysis may be least possibility.
I'm sure that madam must be the senior person. Sorry. Here, what I will find the difficulty, probably personally, I may not be able to locate everyone, but I understand the way in which you are analyzing.
Yes.
Divya will have to learn from such senior persons. What's the madam made the point that periodic paralysis will present in some different way. It will not be starting from one and then gradually progressive. Because it's a one-time problem. Whatever hypokalemia, then hypokalemia will involve all the 4 limbs or respiratory. It depends upon severity, but at least involvement will be at a time. Here, what the madam said that initially there was fever, gastroenteritis or some GI infection. There was some interval, and then the weakness started, which was also initially lower limbs. You said even both lower limbs almost symmetrical, and then gradually it reached to the trunk and then the upper limb. That means it was progressive. Progressive also, if you see, that is from the lower limb to the upper limb. That means ascending variety of the progress. Progress is also, you can label it that it is ascending. And now if we say only the point, usually we don't expect the fever during this type of the neurological presentation. In a case of suppose simply if we say GBS, because it's usually what we say is a post-infective, right, immune-mediated polyneuritis. And therefore, usually fever at the time of neurologic presentation has gone. On the one of the points that suppose if it is strongly indicating the GBS, but suppose persistent fever, that you should keep the mind open that really is it GBS or something else. Some autoimmune other disorders can also present in this way. But usually common story or commonly what we are accustomed to see these GBS, that usually it is a post-infective. And during the time of neurological manifestations, usually fever is not present. So that's why I asked the question twice to you to make it clear. Even still fever was there with the neurological presentation. And if it is not, that favors. And that what Madam said, that you can make this point to differentiate that how it does not favor the periodic paralysis. And then likely neurological problem. And then neurological problem, as already we discussed, that likely to the post-infective. Even the post-infective you can take, started from the lower limbs, progress to these upper limbs. So it's a progressive. And progressive also bilateral symmetrical. So you can make at least inference from this history that is a likely post-infective, probably lower motor neuron type of lesion, bilateral symmetrical, gradually progressive, and ascending variety. I think it starts from lower limbs to upper limbs. So that, ultimately postgraduate should for undergraduate, it's all right, whatever they say. But postgraduate, from the history, you have to derive the meaning, inference, that ultimately what you mean by it. And that will give the idea that what type the story is likely. That will give the further thought process. Here the case is one illustration for us, but from that illustration, we want to learn that how we can go for the further thought process and work up. Right. So I think lot many points you have mentioned. So now, Divya, again, if I come back to you, we are thinking that likely it is a post-infective lower motor neuron type or flaccid type of variety of this neurological problem.
Hello,
Right.
Sir, with your permission.
Yes, sir.
I'm Dr. George.
Yes, sir.
Sir, usually GBS, we call it post-infective polyneuritis, where there won't be any fever. But sometimes even GBS will go with a short history of fever followed by weakness and other things.
Right.
And because we have also recurrent and relapsing GBS also, where it may go for months and years also. So at this stage, let us also consider one a GBS, and second thing, a neuropathy, just like
Of course, and that's why I said absolutely what Dr. George said. That is number one for the postgraduate. Usually, as a teacher,
PG should be first think of GBS.
Yeah, as a teacher, gradually I'm learning that go for the first classical picture.
Yeah,
and all of us know that the patient does not present with a classical picture every time.
Yeah.
There are some variants. There may be some difficult points to explain, but I think that as a student we can take it later on. First, try to learn the very classical basic picture, right?
Yeah.
So I think what sir said, you said bladder bowel involvement is not there. GBS usually is not having, but sometimes it can also be there, as sir said, for the fever.
It can be even para.
Yeah. So the point is, I think unusual or the variant we will take later on. But first, let us try to understand the basic or a classical picture, so that our classical picture is imprinted in our mind, and then we'll try to learn the variants or the unusual presentations.
Okay, sir.
So now, Dr. Divya, coming to that again, then what is the anatomy? Which part of this CNS is gradually we decided that yes, it is a neurological problem.
Sir, one point I want to ask.
Yes, madam, please.
Dr. Divya, can you elaborate on the sensory symptoms?
Yeah.
Sensory symptoms.
What madam wants to know that you said the motor weakness or deficit, yes. Along with that, madam wants to know, is there any point?
Because you have given main complaint sensory symptoms, sir.
Yeah.
I want you to elaborate on the sensory symptoms also.
Yes.
How it progressed, what are the symptoms you have asked for?
Any idea, Dr. Divya? Can you take this?
She will tell, sir. Tell the sensory.
Yes, sir. Sensory system, the child had picking and painful sensations in the lower limb, sir. As of now, the child had only in the lower limb, sir. But she was able to feel the clothes on her body. And while she was wearing slippers, she was able to feel the footwear. While she was given something to hold also, she was able to feel those objects on her body, sir. So as per history, sensory system involvement is not there as per history as of now, sir.
Yeah, I think what Miller wants to know may not be at present, but I think in this illness, yes, sensory component was also there. That's what I think we should make it clear.
So you said pain and paresthesias, that is the tingling and numbness.
Yeah.
I think that also goes in favor of sensory, pain and tingling and numbness, right?
So the point is here the motor deficit as well as sensory component. And that's how it will help us for further take up. There are different varieties. There may be only motor involvement. What do you call it, Divya? Any idea in GBS?
Yes, sir. Pure motor. Mostly GBS is pure motor, sir.
What do you call it? There is a variety of this GBS.
Acute motor axonal neuropathy, sir.
Yeah, it's an axonal motor deficit. Right. And when it is both, what do you call it?
Acute motor sensory axonal neuropathy.
Yeah. So here I think we can even gradually give the thought process that this is likely the second variety. where both the components are affected, and somehow it is more common also. So I think madam wants to know that whenever you go for the presentation from your history, try to prepare the background, that what type of the disorder you are going to consider and what are the favoring points in your present case. So anyway, that's good. Now again come back, always keep in mind any case. I think not only nervous system, more clear in the nervous system, but any system, first always think the anatomy. Now where is the anatomy? It's a central or it's a peripheral? Go for broadly. Who will take it? I think I'm expecting some other students to speak, please.
Any other pages?
I think Dr. Nikita, somebody said the name, so I remember the Nikita. Nikita, first I request you, if you don't mind, please keep your video on.
Good evening, sir. Yes, sir. Good evening, sir.
Nikita, I want to see your face, please. I hope that you are able to, or suppose if you are working or somewhere else, okay, you can just participate. I think I'm sure that you must have heard us. And from this, what is your point to say the anatomy? Which part of the central nervous system is affected?
Sir, central nervous system may be affected, sir. Actually, there is a previous history of loose stools and followed by weakness. I'm sorry. Sorry, sir. Peripheral nervous system is affected, sir.
Okay, good.
Yeah. It is the peripheral nervous system.
Yeah.
Peripheral nervous system is affected.
Nikita, I think always you know that is also. Are you in which year residency you are doing?
Final year, sir.
Yeah, the teacher wants to know because accordingly I can ask the question. Then final year, then I'm expecting lot. Probably which one may not be expecting from first year resident. Now, very nicely you answered. As a whole, if it's a neurological problem, then as you said, that here it is the peripheral nervous system involvement, there is no central. Can you just make the comment that why not central? Or in other way,
Sir,
in other way, suppose any central nervous system disorder is there, how commonly they present? Common manifestations, please.
They usually present with seizures and cranial nerve involvement will be there, sir, along with the weakness. But here the weakness is there with the preserved sensory system, and there is a progression of the weakness, sir.
Okay. Anyway, I think you can take it in this way that usually suppose central nervous system is affected, then probably there should be the manifestations of the disorders, like very rightly you said, impairment of consciousness, maybe seizures, right? Or even the loss of some cognition function, or even the orientation of place, person, memory, all these disorders are going to be there. I think sparing this, here we decided that only the motor deficit and sensory involvement is there. So it is likely the peripheral nervous system. Very good. I think always think in this way. Now the next question, Nikita, you can mention your name of your friend, your colleague. Always what the smart student will do, mention the name of the friend so that she can be free. So who is your friend on the screen? Can you just tell me the name? Anyway, always, I want that all the students should on screen speak. I will say without any hesitation or fear, with smiling face, even do the mistakes also with a smiling face. That's good. Now, the next question which I want to know from the students, that now the peripheral nervous system, then which part is affected peripheral nervous system? Peripheral nervous system, if I want to remind you, is it anterior horn cell? It's a peripheral nerve. It's a neuromuscular junction, or it's a muscular problem. Let us try to give the thoughts in this way.
So, Nikita, as sir rightly said, is it at the anterior horn or nerve or muscle or neuromuscular junction? Where do you want to put the lesion?
Sir, nerve.
Very good, very good.
I think sorry. Yeah, Nikita, I would try to just sensitize you in this way. First you should know what are the characteristics of anterior horn cell. Just first, all the students, let us try to learn and then think regarding our case. What are the characteristics of anterior horn cell? Can you just scale some specific features? Anterior horn cell disorder.
Poliomyelitis.
No.
Okay,
What
no,
are the
not-
characteristic features?
What are the characteristics? That means what happens to the tone? What happens to the DTR? What are the other features?
What
Just
about
No, it
characteristics.
is
nutrition?
a lower
Nutrition?
motor. No, it is a lower
Yeah.
motor neuron
Absolutely.
hypotension, sir. So there will be a hypotonia will be there, sir,
Right.
and reflexes will diminished reflexes.
Yeah.
Okay,
very good.
diminish or absent. But what is the, all the things will be there in all peripheral nervous system disorders. But what is the
Hansel, is there any other specific feature?
what is the characteristic?
Anything related to muscle, like fasciculation or?
Oh,
Yes,
sir answered
yes,
you.
so fasciculations will be there.
Yeah,
to lower motor
fasciculations and
neuron.
fibrillations.
In the in the exam also, some examiners are there to help you.
Yeah.
Right. So here I think Dr. George is doing that job. That's good.
Yeah. So
fasciculation is a characteristic of among besides all other features. And now can you give the Nikita one example besides polio? Now I am sure that you might have not seen the polio. Have you seen any patient of polio?
No. So what are the other Andrew-Hansel disease you know?
Which other Andrew-Hansel you must have seen probably by third year? It is congenital.
Spinal muscular atrophy.
Very good, very good.
Very
so
good,
try
very
to remember. Anyway, spinal muscular atrophy, I'm sure if you've seen the patient, the fasciculation over the tongue, you must have seen.
Yes,
Yeah, and from the distance, so you can make out that this is the probably spinal muscular atrophy, right?
Sir,
I think
another thing I want to add, this child is around 12 years. Usually spinal muscular atrophy, your wedding Hoffman will be around 6 to 6 months. So what are the diseases you see at 10 to 12? That is first and second decade.
And it reminds me, Nikita, somebody asked in the exam, when the last case of polio was reported in India? Because we have not seen since many years, somebody would like to ask.
True. It's true.
When the last case of polio was reported in India, and when reported, WHO reported India as a polio-free country.
So
these are the questions people are going to ask you.
2013.
Yes, Nikita, can you repeat?
2013.
Okay, in 2013, what was the event regarding polio? Last case or declared as polio-free?
Last case was declared in 2013, sir. 2015, India was declared as
Okay, you are nearer but doing some mistake. But I will say that not that bad because that date we may not remember. But I'm asking the date. You should remember the date. What is the today?
Jan 13th.
13th January, and that was the date. That's why even I remember immediately. 13th January 2011. That was in Havara, West Bengal. Last case of polio was reported in India. I think these events that is expected from the pediatricians that we should know. And the WHO declared the polio-free India, I think in 2014. So that at least, anyway, apart from this case, some examiners may ask this type of questions also.
So today being 13th January, we should remember.
That's why, sir, I could recollect it immediately because 13th January.
True, sir.
And today is also 13th January.
Yeah.
Anyway, coming to that, what is the characteristic of neuromuscular junction? Suppose I will say.
Hello, sir. Hello.
Nikita or anybody else?
Hello,
In
can I
neuromuscular junction.
Yes, sir.
Doctor.
Sir, you are muted. Anyway, Nikita, meanwhile, you can take it.
What are the features of neuromuscular junction?
Sir, in neuromuscular junction, weakness will be equal in both proximal and distal muscles with muscular atrophy will not be seen, sir, and the tone will be decreased with either deep tendon reflexes, either they will be normal or decreased, sir, and the plantar response will be usually flexor and
How will be the activity of the patient?
I think, Nikita,
throughout the day,
diurnal variation will be there, sir.
Yeah.
Diurnal variation will be there, sir.
Yeah. How it will be? From morning to evening, what will happen to him?
as a muscle, as the acetylcholine reserves will be lost, the child will fatigability of the muscles will be there at the evening. So by the evening,
Okay.
by the
So-
end of the day, they will be decreased that.
Nikita,
Okay.
Nikita, that is your explanation, but you know how the patient will complain.
What is the patient's?
Patient will come, and you know, many clinical manifestations may go later on sometimes, but the patient may come to you, easy fatigability.
Fatigability.
And fatigability
Causing
particularly
a
as you,
fatigable weakness with
yeah,
more there will be more of cranial and proximal muscle weakness will be more
Yeah.
complaints by the.
And what will be his eyes?
There will be
Anything-
ptosis, sir.
yeah.
So drooping.
You know, ophthalmoplegia.
Drooping of
Yeah. In the morning, he may be perfect. As the evening comes, he'll have drooping, he'll have
progressive
weakness.
child
No?
will be
So
complaining of
diurnal
weakness.
variation.
Yes.
So I
Yes.
think ophthalmoplegia, drooping, easy fatigability, facial muscle weakness is more compared to other muscles.
These are all
And later on with the severity it may go. So I think that's a neuromuscular junction. You can keep it. Okay. Then what is the peripheral nerve involvement characteristic? Who will take it? Dr. Divya, you can take it. What are the
How does the
characteristics?
peripheral nerve?
Any disorder, not necessarily GBS.
Any peripheral nerve,
disorder.
what are the features? Nerve disorder.
Nerve disorders, mostly distal involvement will be there.
Very
sir.
good.
Very good. That's the first point.
How does the patient complain? Distal
Yeah.
means?
Child will not be able to, while walking, he cannot grip his footwear, sir.
Yes.
He cannot button his shirt or he cannot mix his
Okay.
food.
Very
or,
good.
Right.
I think very
Buttoning.
good, very
Those are
good.
the distal. Right.
And how any muscle disorder will present?
muscle disorders, mostly they are proximal, sir, except one
Yeah.
disorder, that is myotonic dystrophy, which is distal, sir. Rest all
Yeah. Proximal
But-
means what does the patient says to you?
Divya, how the patient will come to you?
the child cannot get up from sitting position, or
Very good.
by performing daily activities, he cannot comb his hair or he cannot lift his hand.
Very good, very good, very good.
That is the muscle involvement.
So I think now we are clear that peripheral nervous system disorder presents in this flaccid variety of disorder, motor deficit, maybe the anterior hulsel, maybe the peripheral nerve, neuromuscular junction, or the muscles. And I think characteristic we discuss. Now we are
Yes.
clear. Now,
Yeah.
Nikita, from this story, what is likely in our case?
Sir, it could be nerve involvement, sir, because distal muscles are more involved
Okay.
than proximal muscles, sir. And
Now
with the
Now the next question, Nikita,
sir,
is why not it is a polio? You know, we are free from polio, but even we have the threat for the polio.
yes,
And
sir.
therefore we should be very careful. So it is possible that this may be the case of polio for the Divya to
Can it be
report.
polio? What is the difference between polio
So
and
how
this?
will you, in point is, how will you
Polio-
differentiate GBS and
in-
polio?
Yeah.
In
Symmetrical
polio,
involvement,
there will be asymmetrical involvement.
Okay.
Okay.
Polio is asymmetrical. You want to say? Tell
Yes,
the
sir.
features of polio and GBS difference.
And polio will be only motor involvement will be there, sir.
Hmm.
There cannot be any sensory involvement.
Hmm.
And
So polio is asymmetrical. GBS is symmetrical. You want to say?
yes, sir.
Okay. What sensory involvement do you expect in GBS?
It will preserve the
In this case,
sensory
child is telling that paresthesias are tingling and numbness.
tingling and numbness. Yes, sir.
So does it go with some peripheral nerve? GBS? Pain
Yes,
and
sir.
paresthesias are features of GBS, whereas in poliomyelitis they may not be there, right?
Yes,
Asymmetry, polio,
And
right?
in either of these two, in which condition bladder involvement is common?
Bladder.
sir.
Involvement of urinary bladder is
Urinary
common in which condition? Polio or the GBS?
GBS can.
On the contrary, polio it is common. GBS urinary bladder is not common. An unusual variety, yes, but may not be even initially, can go for the later on. Anyway, but these are the few points which you can keep in mind. Asymmetricity is a very strong point. In polio, it's always present with the patchy. That may be some right upper limb and then left or lower limb and like that. That type of the presentation is common with the poliomyelitis. Anyway, now in the history part, Dr. Divya has taken so many negative points. Dr. Divya, what was your idea
Sir,
of
initially,
mentioning the negative points?
yes, sir. Initially, I wanted to rule out if it was upper motor or lower motor. I wanted to differentiate, sir. So no history of seizures, altered sensorium. I have taken that history, sir. Later, I wanted to rule out cranial nerve involvement was there or not, sir. So I ruled out all cranial nerve involvement, sir. It came out to be that cranial nerve involvement was not there. Later, if child had any recent insect bites or
reflexes, UMN and LMN, tone and reflexes. Here, what is the reflexes?
I think,
So
sir,
and
probably.
For examination, he is
Sir,
not-
she's talking about history, sir.
Probably she will come in the examination point.
Fine.
But the history point, what Divya I want, and for all the postgraduate students, usually what most of the students do, that very long list of this negative history, very long, 10, 15 points, probably which you should take care to mention in the negative history, whatever the condition, suppose if you are thinking, and regarding that condition, probable etiology, whether is there any point indicating, suppose in this case you mentioned no history of immunization, recent. I think that's good point, because some of the vaccines are known to press or following that vaccination, GBS is possible. So accordingly, what I mean to say, or suppose no history of gastroenteritis or recent respiratory infection, you can, because following that infection, GBS is known. So like that, you can mention the negative history. Second, for some differentiation, suppose GBS and polio you want to differentiate, or some botulism if you want to differentiate. That's why honey or some substance or food you can mention. So that's the second target, what you will keep in mind, that nearby differentials, whether they are likely or unlikely, that you can clear from your negative history. If it is there, probably it helps. If it is not there, you can very easily exclude or consider less possible. And third group you should keep in mind, probable complications following your disease. Suppose here GBS, you want to make it clear, is there any respiratory involvement? Because that is a life-threatening complication. And therefore, suppose speech is not affected, respiration is not affected. If you mention, it indicates that there is no any complication of the disease. So the point is, in the negative history, always try to mention regarding whatever the thought process or condition if you are considering, etiology regarding that condition, or second, nearby differential conditions for differential diagnosis which you are considering, whether it helps or exclude, and third, possible explanation, complications. So I think this should be an idea. Okay, so this was the just point. Now having this history, who will go for the summary? I think all the students must be knowing. Now at the end of history, it is very common in DNB and MD examination that we'll have to give the summary. And summary means not repetition of the history, just your interpretation, your inference, and to prepare the hypothesis that what you are thinking likely condition in this patient. And that should be, I would say, 8 to 10 lines. You should make this habit regularly in the round so that in the exam you don't find the difficulty. I think, is there anybody else student who can make the summary, please?
Sir, before going to summary, I just want to ask you a question.
Yes, sir. Yes.
Sir, she mentioned there is no deficit, abdominal pain and no history of abnormal color of urine.
yes,
So, yeah, why did you ask for that, doctor?
Yeah.
sir, I wanted to have porphyria, sir.
Yeah.
There are 3 porphyrias which can even present with neurological.
Yeah, okay. Before going to porphyria, if you mention the porphyria, the pattern of distribution, what you have seen in your children and what you expect in the porphyria will be the same?
Sir, in porphyria also ascending paralysis will be there, sir. Like this similar case. But there will be other symptoms like photosensitivity, pain abdomen, and discoloration of urine on long standing. So such complaints this child did not have, sir. So
yeah, what we see in porphyriasis predominantly proximal muscle weakness. Okay,
Yes.
not of peripheries. It is seen in the proximal, like your trunk, that part will be much affected compared to your distal, what you're seeing in your child. So I appreciate that you have mentioned that abdominal pain and abdominal pain to consider porphyria, but the pattern of involvement is different in porphyria compared to GBS.
Yes. I think Dr. Venkatraman has brought a very good point, but I would like to draw the attention of all the students. In the exam, don't invite the trouble. Right. I think porphyria is not so common. And why unnecessarily we should mention over here? I think suppose everything you have ruled out, it may happen so that everything you have ruled out, and still if you don't have answer for this type of presentation, then probably will consider some rare conditions. But best way from the exam point of view, you can avoid, but it's even good, suppose if you want to go for good performance in the exam, that even if the examiner, like Dr. Venkatraman asked, Dr. Reddy asked that, and if you are knowing this porphyria, then it's well and good. But as far as possible, suppose if you are, and always rare conditions should be kept at last. But I think it was a good question as what sir raised, and Dr. Divya also answered. That means she has come with a good preparation. It's a good thing. Very nice. I want the
Sir, one more question, sir.
Yes,
so
sir.
she said there was a history of similar complaints at 7 years of age.
Yeah.
Again, she had one more. Forget about the history of pain for this many days. What else possibilities other than GBS do you suspect? I'm asking, it may not be an infectious etiology.
Yeah. Absolutely.
Because we are having a long duration and it is a recurrent variant. So what else you'll consider apart from GBS?
Apart from GBS, we can also consider chronic idiopathic demyelinating polyneuropathy, sir, which CIDP, sir, which will have relapsing and remitting episodes, like this child also had.
Okay. Okay. If suppose this child is having a periphery and that two extremities, okay, palms and soles are predominantly involved and having a recurrent history. Okay, what is your thought process?
I think good question.
Sir, palms and soles and are recurrently involving means it is axonal neuropathy, sir. Could be any axonal neuropathy, sir. It could be.
So my question is either a small fibers or long fibers. Which one is predominantly involved?
Sir, soles involvement means generally large fibers, sir.
It's a small fibers. Usually they are small fibers. Long fibers are the you have posterior column signs, predominantly or B12 deficiency kind of thing. Tabes dorsalis, though we don't see much of it syphilis these days, but you think consider with the long tracts. Small tracts like where peripheral neuritis kind of thing, particularly in diabetes, polyneuritis multiplexa in autoimmune diseases. In that cases, you'll see. So the glove stock type of presentation. And here you're having a radiating and from the small limbs to proximal muscles as well. Okay, so it is not of a typical small axons. Okay, thank you.
You said that DD is chronic relapsing polyneuropathy. Can you fit this in the chronic relapsing polyneuropathy? If so,
may not be, sir. May not be, sir. Yeah, may not be, sir, because that typical what she has mentioned is a progressive type from extremities from proximal. That the only point I would like to raise is
neuropathy, just like similar to GBS, where it's a very So I think it's unlikely.
The point what I want to tell her is, as a postgraduate, it's first thing to know is a GBS, but the presentation when it comes to only glove stock type of variety, what else to consider?
True.
Yeah, thank you, sir. Thank you.
Fine. I think, Dr. Divya, I miss even this PATS-IAP. Can you take it in details that how much importance to be given that? You said at age of 7 years or so, some problem was there?
Yes, sir. At 7 years of age, child had high grade fever spike, sir. Later, she had weakness of lower limbs, sir. She couldn't grip her slippers then, and she couldn't get up, sir. It didn't progress up properly. Lower limb weakness was there, sir.
It was restricted to lower limbs only.
Lower limbs, sir. Yes, sir.
Okay.
And after she was taken to nearby hospital, she also had gait abnormalities, sir.
Yeah.
So she was taken to nearby hospital. They gave medications and they gave splints to wear, sir. After 2 months, subsequent visits, after 2 to 3 months, she started going to school wearing those splints, sir.
Was there any residual weakness?
Yes, sir.
So, Divya, was there any residual weakness?
Sir, there was residual deformity at this presentation, sir.
Okay, then what was the likely problem during that age, 7 years age?
At 7 years of age.
Yeah, what was the diagnosis? As you
it was-
said, at the age of 7 years, problem started with the fever. There was the weakness of lower limbs, and even the restricted to only lower limbs. For a few months or weeks, as you say, whatever the treatment was offered, we understand it must be just supporting, and child recovered. But still, you say that there was some, even the sequelae, and you said even some deformities, you say?
Yes, sir. The child had.
What deformity? What deformity?
The child had cavus deformity, sir.
Okay, then what is likely? What is the likely diagnosis? Suppose if you have confirmed from the old records, it's all right. Suppose not available, what will be your thought process? Was it GBS? If you don't say, I will ask the direct question. Was it GBS? Was it poliomyelitis? Was it something else? Number one question. Second group the question, with that reference and this present illness, how you are correlating now? I think that's the second we'll have to do. So first answer the first half of the question. What was the diagnosis for at that age 7 years?
Sir, at that 7 years, we didn't undergo a proper evaluation, sir. But because of...
what will be your interpretation, your inference? You may not have the...
Bilateral symmetric weakness, which was ascending, sir. Which came down on its own, medications in 2 to 3 months, residual cavus deformity, which continued up till present admission, sir.
So the point is, what is your diagnosis? What is the likely problem? As even I asked you the direct question, again, was it GBS? Because recurrent is possible. Or was it polio and now the GBS? Or even some third condition? What you are thinking for the...
Do you want to consider the third condition with this?
Yes, sir. I want to consider hereditary sensory motor neuropathy also, sir. Okay. As my another possibility. I can rule out poliomyelitis, sir, because the child had symmetrical bilateral weakness. So I can rule out that, sir. GBS, it can be there. It can also be there, sir, but in again relapsing after so many years.
So you want to consider, now we are keeping two, one relapsing polyneuropathy, another one is hereditary motor sensory neuropathy. You want to keep two at this stage.
Yes.
Was there sensory symptoms even when at 7 years of age in the last admission?
Yeah, what the madam wants to confirm? Any idea?
On probing, they did not tell about any sensory involvement, sir, back then. Ma'am, back then we asked about sensory involvement back then, but they did not tell any sensory involvement then, ma'am.
Okay.
That time they had only she had only distal weakness.
No, sir, no, ma'am. Initially distal, which progressed to proximal, ma'am. And
but only lower limbs.
No, sir. They told the child was most of the time on the bed, sir. So we considered it lower limb, but it was progressive, sir.
Okay. Now this follow-up of the 2 years, Dr. Divya, as you said, the deformities, which you already you have seen.
Distal means distal muscles in the lower limb and distal muscles in upper limb. Distal doesn't mean only lower limb.
Yeah.
See, that you should have clarity in that. Distal muscles are distal muscles of lower limb and distal muscles of upper limb. And if there is progression, then they will involve the proximal muscles of the lower limb and the proximal muscles of the upper limb.
I think what the madam said is very, very important, valid point. Try to clarify. Was it restricted only lower limbs or even upper limbs and other places? Number one. Second, whatever, suppose if you say restricted, then was it with this really distal and then really progress to upper, even in upper limb, lower limbs also, it can start from distal and progress to the proximal. So what was the real issue? And that will give you some insight that what you should consider. Anyway, but suppose retrospectively now, if you have to consider either of these two, polio or GPS, with this at the age of 7 years, what it favors? What you will consider?
Because of the another relapse again at 12 years of age, 5 years later, we
Divya, if I ask you the direct question, sorry to interrupt you. I was knowing that what you are going to respond the way you started. Deformities are common with which condition? With poliomyelitis, residual deformities are common with which? GBS or polio?
Poliomyelitis.
Yeah. And here if you say the deformities, right. So either we don't know that even during that time also it must have been worked, at least because with the government of India's guideline, but still. And then third possibility, I think you can consider beyond that, that when we are not able to explain even the past history and the present illness, we can keep the various possibilities with our thought process.
Were the splints given for both limbs? Or
yes, ma'am.
Was it asymmetrical or symmetric?
Symmetrical, ma'am. Splints were given for both the lower limbs.
So polio we cannot.
Polio we will have usually asymmetric, and they will have usually splints or braces for one limb.
So the point, so the point is, you know what? Actually, I'm trying to give the insight that probably polio clinically and even with the present status of our country, we don't consider. Number one. Number two, GBS probably with this deformity is not acceptable.
True.
Recurrences can occur. Then the question comes, I think we should go for some third thought process.
Yes, sir.
That this can be beyond the GBS and polio. I think if you come out with this, and if you go for workup during this episode, probably we will learn something new condition. And that's the thing that how we learn. I think this is the beauty of the history, that if you get the details of correlation, we have the several thoughts and we don't know what is the diagnosis in particular patient. Later on we come to. Right. So I think now with these ideas, ultimately summary, summary is very important. Every student at the history should be able to give. And summary here will not be able to give the diagnosis. You can prepare the hypothesis.
Yes.
That what type of problem it is, right? And then diagnosis can be, even thought process can be changed with examination, and even with the investigations may be totally new. So it does not make any difference.
So as per Divya's present history, sir, because it is symmetrical and also deformity, probably we are keeping the polio aside. GBS with deformities, so we cannot consider. So we are going with another or some more possibilities. I think we'll go ahead with the other examination. Fine.
Sir is always helping the students.
Sir, one question, sir.
If you don't speak the summary, I will speak the summary. So that he helps.
Sir, one thing I would like to ask.
It is 9:40,
yes, Doctor, ready, please.
Sir, one thing.
40, we'll go for
Dr. Divya, would you like to consider any metabolic or toxic neuropathies at this point of time? Exposure to anything like history of pica kind of thing?
History, she mentioned that there was no pica, sir. If you can just see the history, negative history, she has clearly mentioned.
She ran too fast, so I couldn't recall that. So she ran
too fast.
Why did you take history of pica?
Why did you ask for that, doctor?
Let's to rule out lead poisoning, ma'am.
Okay. So, would you like to explain the same with lead poisoning in this child? How do they present rather in a straight question?
Neurological involvement will be there, sir, in lead neuropathy.
Okay. It is motor and sensory, or motor without sensory, motor more than sensory. Which one you would like to explain?
Not sure, sir.
It is motor more than sensory. If I'm not wrong, Dr. Venkatramana Reddy, sir, I don't know who it is, but see, this case, actually, this is for the post-graduates. That's a very good thing that we are progressing and we are going ahead.
I just want to tell her pica history. So I see if at all she mentioned is a very good thing. Pica more of like lead poisoning is very good, but it's predominantly motor than sensory. That's it.
Thank you. Thank you.
So, to complete the list, what are the drugs which can cause
Yeah.
peripheral neuropathy.
Absolutely, absolutely. Even common drugs, which we are treating, and for that recommendation has come to prevent that complication. May not be, I will say, this type of the classical neurological deficit, but yes, polyneuropathy.
Some anti-tuberculous drugs.
Anti-tuberculous drug, yeah, sir is
Isoniazid, metronidazole, phenytoin, amiodarone, chloroquine can cause such kind of neuropathy.
Okay, Nikita is speaking behind the curtain. That's good. But she is answering. That's it. Her answer is absolutely right. And you know that we learned in the recent National Tuberculosis Elimination Program that we have increased the dose of INH. Even some deficiencies common in our malnourished children, they may not complain. And therefore, even to prevent this complication, the pyridoxine supplementation has come. Again, as Sir said, this question may be asked by any examiner.
Yes, sir. Yes, sir.
So you should
mostly
know.
anti-tubercular.
Excess pyridoxine can cause.
Yeah.
It is used for treatment. Excess also will cause.
Absolutely.
Which vitamin can cause peripheral neuropathy?
Yeah.
Which vitamin deficiency?
B12 deficiency.
So what symptoms you have asked to exclude B12 deficiency in the negative history?
Hyperpigmentation.
Okay.
Anything regarding diet?
Vegetarian, pure vegetarian diet.
Yeah.
Anything in the tongue?
Bald tongue.
Bald.
Glossitis.
Bald tongue. Glossitis.
Bald tongue, you will get in iron deficiency anemia.
Even phenytoin is also
Yeah.
to cause peripheral neuropathy. Some insecticides, they'll cause peripheral neuropathy, right?
So I think this is the beauty of this clinical case discussion.
Yeah.
That we might have restricted our thoughts to the only GPS, which happens very common in our common rounds. But you know, when we are not able to explain, we go for the multiple points. And it may happen so that you may be able to diagnose a rare condition.
Yeah.
We'll have to continue in this way, that consider the common, not convincing. What is the next? Try to correlate with the past. Still not convincing. It is possible, but everybody will say this is not. I will say palatable. Then you think something else. Even you open the book, read something else. Even those who are reported, as Dr. Reddy was mentioning, uncommon porphyria or even other situation, and then we'll be able to diagnose the condition, which you can report in the journal, Dr. Divya. So that's the whole academic exercise, how we should do. Very good. I think we have taken good time. It is said in most of the medicine that 80% diagnosis should be revealed from history. And this is more true for this neurological case. I'm gradually learning from my friends neurologists, particularly Dr. Rajesh Udani, that 80% diagnosis of neurological case should be clear from the history. 10 to 50% should be clear from examination, and only 5% for confirmation, what we have thought of. So I think that we should keep in mind. Now, Dr. Divya, you can share your PPT for examination.
Sir, one more, sir. Infections.
Last but not
Yes, madam. Yes, madam.
Infection, because there are some infections which cause deformity, peripheral neuropathy.
Yeah.
So we should also mention those infections in the history, negative history. What are the causes of infections which can cause peripheral neuropathy and deformities?
Yeah.
Enteric fever.
No. Any chronic
deformity.
It's a chronic
disease.
Chronic infection.
And neurological enormity is common.
Neurological deformities, chronic.
And it is more common in the states of Orissa, Andhra, and even some parts of North India.
And they will do a diploma also for that.
And one of the anti-tuberculosis therapy drug is given as the treatment. I think Divya, now it is sufficient.
They will do one diploma also for that.
And that is leprosy. Yes. Very good, very good. I think good discussion. Now you can share your PPT and examination, please.
Yes, sir. 1 minute. Last but not the least.
Yes.
Intestinal malabsorption, some ataxia, If there is some dissociated anesthesia, we can even go for A beta lipoproteinuria, which is very rare.
Divya, how as sir mentioned, how the A beta lipoproteinuria patient will present? I have seen at least 2 cases.
Yes, sir. Yes, sir.
And as sir said, commonly the patient starts with the infancy or young toddlers. First presentation is chronic diarrhea.
GAT presentation.
And that containing the, I will say, fat or the oil.
Yes, sir.
And later on, the patient develops the anemia. And the peripheral smear, he will mention some irregular RBCR seen, that is acanthocytes. And then the gradually patient goes for this hypotonia and even
ataxia also.
Ataxia. Because spinocerebellar involvement is very common. And that is due to vitamin E deficiency. And E deficiency developed with the fat loss. I think so nice story, sir. You reminded.
In fact, vitamin B, nice. E we will give for that.
Yeah. So I think whether, today we discussed Divya, I think after a year, you may get the patient of A beta lipoproteinemia and you will be able to diagnose immediately if you have discussed. That's good.
Right.
Okay.
Sir. Okay. We'll proceed.
Yes.
Right, ma. Proceed.
Yes, sir.
You can share your PPT and go for
share your PPT.
Sir, is it same, sir?
Yes.
Is
it same?
Visible, sir.
It's available.
Clinical examination. General examination. Posture. The child was lying on the bed with flexed arms, lower limbs extended at the knee, bilateral foot deformities noted, no pallor icterus, cyanosis, clubbing, koilonychia, lymphadenopathy, edema. No.
Can you explain the foot deformity?
Yes, ma'am.
Foot drop, or is it?
Madam, she has posted a picture, madam. Divya, please show the picture. That will be better.
Ma'am. It's in the last, ma'am.
Anyway,
if you can keep the picture, it will tell you a lot. If you can show the picture and talk about it, it is better.
The child had a valgus deformity at the knee joint, varus deformity at the ankle joint, with longitudinal arch, high arch longitudinal in the sole, suggestive of cavus deformity.
Yeah, it's a pes cavus, absolutely. Okay.
Keep the entire picture of the child now. Keep the entire picture of the child and just explain that. Yes, this one.
The child was in supine position, flexed at the elbow joint, and cavus deformity of the foot was noted. Previously, I've mentioned in the past history that the child was given the foot orthosis. These are the splints with which I circled. These are the splints with which, at 7 years of age, with which she was going to school, sir. Later, at this presentation, she presented with these complaints, and in general examination, we could also note these deformities.
Okay.
SMR staging: breast stage 4, pubic hair stage 1, vitals, temperature 98.6 Fahrenheit, pulse 108 per minute, regular, normal volume, normal rhythm, no radial or radiofemoral delay, all peripheral pulses well, respiratory rate 22 breaths per minute, blood pressure 100 by 60 mm of HG in right upper limb in supine position, anthropometry. Anthropometry length is between, because the child was in supine position, we took length, sir, between 10th to 25th centile, weight is less than 10th centile. Systemic examination. Because my history was pertaining to central nervous system, I would first like to examine nervous system. Higher mental functions. Child is conscious, coherent, cooperative, well-oriented to time, place, person, immediate, recent, and remote memory intact, speech, comprehension, fluency, naming, and reading normal. IQ was 90. Child had left hand preference. Cranial nerve examination is normal, sir.
Okay.
Should I read
That's
it?
good. If it's normal, it's okay. We can save the time.
Yes. Motor system examination, nutrition, impression was wasting of muscles in both lower limbs was noted, sir. There was not much significant difference when we could measure both the upper limbs and lower limbs. There was not significant difference, but the overall impression was wasting of muscles was noted in both lower limbs. Tone. Tone was decreased in both upper limbs and lower limbs. Power was elicited at different joints, sir. In shoulder joint, right and left side, 3/5, sir. Elbow joint, 3/5, sir. Wrist joint, 3/5. Finger grip was absent. Neck flexors was 5/5 and extensors were 5/5. But coming to the lower limbs, hip joint power was only 2/5. Knee joint, 2/5. Ankle joint, plantar flexors was 1/5. Toe movement flexors was 1/5, and gait could not be elicited. So power was decreased in lower limb more compared to upper limbs. Deep tendon reflexes were totally absent in biceps, triceps, supinator, knee, and ankle. No evidence of any involuntary movements. Coordination of movements is present in both upper limbs and lower limbs. Superficial reflexes were present. Abdominal reflex was present. Plantar flexor response. Corneal reflex present. Conjunctival reflex present. Anal reflex present. Sensory system. Pain, temperature, pressure on both the sides was intact. Fine touch, vibration, and proprioception on both the sides was intact. But child had loss of sensations in the tip of toes of both lower limbs.
Okay, next.
Cerebellar examination, no signs of cerebellar dysfunction was present. No signs of meningeal irritation. Spine and cranium was normal. Other system examinations was normal, sir. CVS normal. Respiratory system, bilateral air entry, bilateral normal vesicular breath sounds heard, no added sounds. Parabdomen soft, no organomegaly. Bowel sounds are heard normally.
Okay.
Keep the summary there.
A 12-year-old female child with history of fever since 1 month, history of lower limbs since 20 days, history of upper limbs since 15 days, history of pain and pricking sensation in lower limbs since 15 days, past history of similar complaints at 7 years of age, developmentally normal child. On examination, decreased power is present, lower limb more than upper limb with hypotonia and areflexia.
So after examination of such total baby, we had a bit of confusion with the history. Now correlating with the history and clinical examination, tell your impressions. 1, 2, 3.
Yes. Dr. Divya, can you stop sharing for a while?
Yes, sir.
Yeah. So your impressions 1, 2, 3. Fine.
I think where is Nikita? Let her answer independently. What is her thought process? Because Divya might have come with some preparation.
Yeah. Nikita, you tell.
Nikita, I think you are clear from can you summarize the positive findings of CNS? Just positive findings.
Weakness is progressing, sir. More involvement of more lower limbs.
Nikita, for the exam point of view, somebody is asking the positive finding. You can start in this way. That higher functions,
higher mental functions are normal. Sir. Cranial nerve is intact, sir. Sensory systems are intact.
Always go methodologically. Functions, nerves, motor system, sensory system, reflexes, right, like that.
Yes.
So start from higher intellectual functions, cranial nerves, like that. Tell.
Okay.
Yeah. Higher mental functions are normal, sir. With intact cranial nerves and motor system, there is a hypotonia with a decreased power more in lower limbs than in the upper limbs, sir.
Even you must have noted that even the upper limb and lower limb, distal is still power is less. Yes,
Yes,
she has
sir.
mentioned hypotonia, DTR absent, power in both upper and lower limbs affected, but lower limbs more
Lower limbs
affected,
are more
and
affected.
even in both distal muscles are more affected. I think that
And
was
wasting,
More
wasting,
affected than
and wasting is generalized, I
wasting.
think. So. Yeah. Right. Then sensory system, I think again sensory system she described normal.
intact, sir.
Ah.
Yes, sir. Sensory system is intact, sir. And no spinal or any skull abnormalities are seen, sir. With that findings, sir,
I think, sorry,
in
Nikita,
a case of
Nikita, sorry to interrupt you from the exam point of view. I think this
sir,
is a post-graduate discussion and I want that exam going student should be benefited maximum. Suppose these are the summaries,
yes,
simply you can go in this way. Higher functions, cranial nerves normal, mainly motor part is affected, and that is in the form of the lower or flaccid variety. And that you can say that this tone is hypotonia. Power is affected in both the upper limb and lower limb, but lower limb more affected, particularly the distal muscles. DTR absent, involuntary movement absent, coordination could not be examined properly. Sensory system is intact, signs of meningeal iteration and cerebral signs are absent, skull and spine normal, gait I could not assess. So the whole positive finding comes. Now, based on this finding, Nikita, you can put your possibility that how you are thinking now. History part we have discussed in details. Now with these findings, what is your idea?
sir, it could be one possibility would be chronic inflammatory demyelinating polyneuropathy, polyradicular neuropathy, sir. Because why I was thinking in that way, because it is a chronic and slowly progressing disease, which initially also child had a similar presentation at the age of 7 years, which was again gradually progressing, sir. So,
Okay.
and there could be in that in CIDP also child can have this presentation, sir, and other could be Guillain-Barré syndrome, sir. But Guillain-Barré syndrome, onset will be an acute to usually 7 to 12 weeks with a subacute onset, but it cannot be a chronic progressive, sir. The other thing could be a Charcot-Marie-Tooth disease, also known as a hereditary motor sensory axonal neuropathy, could be, sir, because of the classical presentation of the child. She is having a pes cavus deformity with previously sudden on child was having a paresthesias with the sensory system being intact. So I also think of HMSA, sir.
Okay, I think good points you mentioned. Good thoughts. Vidya, what is your ideas?
Sir, I would put in the list of 3, I would put Charcot-Marie-Tooth, the hereditary sensory motor neuropathy, as my first possibility, sir, because child had residual deformity persisting till now, sir. Initially, she complained with similar complaints. Right now, also, she came with same complaints, and she had residual deformity, progressive weakness. Mostly peroneal involvement will be there, sir. So, lower muscle involvement is mostly there in this child, sir. And sensory intact sensory system, but at tip of toes the sensory involvement is there, sir. Like sensations were lost, sir. So it is seen in Charcot-Marie-Tooth, sir. So I would keep that as my first diagnosis, sir. Chronic idiopathic demyelinating polyneuropathy also can be considered, sir. But in that large fiber sensory involvement will be there invariably, sir. So I would, because sensory involvement is not much, I would keep it as my second possibility. And third is Guillain-Barré syndrome I can put, sir, but it is mostly acute or subacute, but such a chronic, after 5 years also she is having similar complaints. So I will entertain it as third one, sir.
Yeah, I think good possibilities you have kept very nicely. Suppose in the exam we have to face, very nicely you can start your discussion the way in which we have done, and you can put it that it is a very classically the problem with the peripheral nervous system. It is very obvious that it is a issue or the disorder with these peripheral nerves. Now, if we think with that direction, probably with the common two conditions, either the polio or GPS, the which already we discussed, probably we are keeping it at the bottom. They are not the as the first possibilities. Then some other possibilities we have to consider. And here at least we can say that it's a very certain that this condition is not at one time, but it was in the past, had some even recovery, but may not be the total with the deformities. And again, the patient has come with this peripheral neuropathy with the involvement of both upper limbs and lower limbs differently, more of the distal variety, and distal muscle involvement is more. That favor used to say it's a peripheral neuropathy disorder. That's very certain. And now from that, if you take it, that means it may be in the form of some either the immune mechanism or some hereditary cause. There are the various syndromes and conditions that we'll have to go in the details and try to locate. As not having the similar issues in the family may not be hereditary, but even the even without family history also it is possible. So we'll have to consider.
This is a consanguineous product, sir. This is a consanguineous baby.
Third degree consanguinity.
Yes, consanguinity is there. So yes, that point is also again then hereditary cause we'll have to consider. And the reason is now, I think we can go, the next question usually will be there in the exam, or I think for the practitioner also, what the parents will ask us. Now, sir, what further we can do? What investigations we'll do so that you can confirm or you can have some ideas and we can go for further workup, right? So I think, is there any faculty want to add something, or should we go for the investigation what Divya has performed?
Yeah, yes, sir, one question I would
Yes, Dr. Reddy, please, yes.
Dr. Divya, have you seen any autonomic disturbances in this child right from the beginning? Okay,
No,
any
sir.
ulceration, non-healing ulcerations?
No, sir.
Okay, any temperature disturbances in the child, like always recording high temperature, because we'll see hereditary sensory.
Why sir is asking all this? Divya, why sir is asking all this?
To rule out hereditary sensory autonomic neuropathy, sir, it and such conditions will have high fever spikes, sir.
So what will you find there?
Autonomic disturbances will be there, sir.
Because in your child you have complained about a fever of recording fever, but may not be that high grade. What I remember, there will be a pyrexia of unknown origin as one of the DD. Yes. They'll have some abnormalities in the iridocycles. There's a pupillary abnormalities, tongue abnormalities, non-healing ulcerations with autonomic disturbances. Then you can consider one as HMSA.
They will
absolutely.
They will not have tears while they're crying. While crying, they don't have tears. Fine. So dry eyes, ulcers.
And hydrosis, yes.
Yeah. So I think here, fever even you can go in the detail, Dr. Divya. I'm not sure that at present fever is there, but even in between also some fever, parents may not complain. If it is mild or something, they may consider it's a part of some practitioner also will consider some other reason and may offer some antipyretics or antibiotics as usual we know in the practice. So I think Dr. Reddy has brought a very good point. Sometimes parents don't complain because they don't consider the part of illness of this problem. But once we ask them, they will commit. And therefore in the history and examination also, some of the questions we can ask retrospectively. And you can mention even in your history that parents need to mention, but when I was thinking that these are the various possibilities, whether should I consider or not, then I ask these questions retrospectively, and then whatever the answer, you can mention. What Sir Dr. Reddy has mentioned, absolutely, regarding fever or ulceration, some ulceration in the mouth, even they will consider something else, that it's some vitamin deficiency and somebody might have treated. So these are the questions which you can ask. I think,
temperature abnormal.
We can also record for orthostatic hypotension.
Yeah. Yes, all the autonomous nervous system disturbances you can keep in mind. You can check even. You can ask positively whether they are noted or not, and that will help us whether should we consider or not. Okay, sweating. I think good points for the discussion.
It can be sweating, also more sweating, less sweating, hypertension, no tears while crying, ulcers. These are all really days. So fine.
Even in a case of even in a case of Nikita, some people may ask, because GBS may be the common case for your MD examination or any postgraduate examination.
Yes.
And they will ask that what are the autonomous nervous disturbances known in GBS?
There will be bladder involvement. Sir.
Okay. What are the other autonomous nervous system disorder?
Increased, hypotension will be there, sir, with increased.
Yeah, sometimes hypertension. Yes,
Yeah, very good.
Tachycardia. Your
Increased blood
arrhythmia.
pressure, tachycardia with sometimes postural hypotension, and there will be
Yeah.
episodes of profound bradycardia will be there, sir.
And the point is why it is important, it is having the prognostic value also. In the
Yes.
patient with the autonomous nervous system disturbances, little bit we are, I will say, hesitant to give the good prognosis because they can deteriorate very fast. Even the obesity and the GPS is not having the good prognosis. So I think these are the certain points in any condition which we can keep in mind. We can verify whether they are present or absent, and that will give us the idea regarding its severity, even its likely prognosis, and even how we should manage it. So I think these are the good points for consideration. Very good, Divya. I think you have brought a very good case for discussion and understanding. I'm sure that you have some investigations to share with us.
Yes, sir.
Because now we'll have to keep in mind the timing also. So you can share your investigations, whatever.
Show the
you have
investigations.
Yes, sir, I'm sharing it. These were my differential diagnoses, sir. Hereditary sensory motor neuropathy, chronic idiopathic demyelinating polyneuropathy, and GBS, as I told. These are the images of the child, sir, I showed just now. At admission, we sent routine investigations. Hemoglobin was 8.7. Total leukocyte count was 2,820. Platelet count was 2,65,000. Peripheral smear showed normochromic and normocytic cells. CRP was positive, being 48 mg per deciliter. ESR was first hour 125, second hour 140. In chest X-ray, there was no evidence of cardiomegaly. ECG was within normal limits. 2D echo showed normal study. Ultrasound abdomen was normal. MRI spine was normal study. We also performed lumbar puncture to do CSF analysis, in which proteins was 3.5 mg per deciliter, sugars was 76, and cytology no cells. Provisionally, CSF analysis also was normal, sir. We also suspected to rule out any infective etiology. We sent torch profile and other viruses. JE was negative, West Nile was negative, HSV 1 and 2 was negative, scrub type was negative, Brucella CMV was negative, Leptospira IgM was weakly positive, sir. We sent for nerve conduction studies, which showed these are the nerve conduction studies, which showed impression suggestive of sensory motor axonal neuropathy of bilateral lower limb more than upper limb to correlate clinically. That's all. These were the investigations we performed.
Okay.
Suggestive of sensory motor neural axonal HSM.
Okay, can you just stop sharing now if you don't have anything to share?
Conduction velocity also normal.
Dr. Divya, have you done the HIV in this patient?
Sir, HIV, HPSAG we sent, sir. It was negative.
Okay,
sir.
negative, okay. So I think it was a good case for the discussion. What ultimately you have considered the diagnosis in this patient?
Sir, ultimately we considered as a Charcot-Marie tooth disease only, sir.
Okay.
Because nerve conduction studies were suggestive of that. We planned for biopsy also, sir. But later the child got discharged at request, sir. They told they'll come back again. So now biopsy have not been performed yet, sir.
Okay, which nerve biopsy you plan?
Sural nerve or peroneal.
Sural is the most superficial, which you can take and that you can plan even further.
Yeah, because not much damage will be there.
Yeah. You know that this is very classical, and now in every postgraduate exam, whatever the diagnosis you have made or whatever your thought process, now you'll have to counsel to the parents. So Divya, how will you counsel to the parents with this your conclusion?
I would like to counsel parents that initially the child had these motor symptoms, but in this condition, there can be sensory involvement also, which can later progress to the child getting claw hand also. So I would like to counsel them about what could the child land into. And as well, I would also suggest them they can, if they have residual deformities, for other occupational therapies.
Dr. Divya, one thing, they don't understand all our medical terminologies, what we are discussing, of course, naturally. So the point is, when you are doing the counseling, and that's why I'm sure that even the now, you must be doing an MBBS course also. They have given the more weightage to the communication skill and the counseling. And I think somehow this part is lacking in our practice also. And to be very frank, the seniors like us, because we were never trained, or even we were never taught even that we have to do the counseling. On the contrary, if you have heard from some of your seniors that we were not even properly talking to the parents or the relatives. Now the scenario is totally changed. We are supposed to, and I think it's a good even in both the ways, for the parents also to understand and to plan for the treatment, for our, I would say, transparency also in our practice, and even from the safety from the legal point of view also. So the point is, now the counseling and communication is very important aspect, and therefore almost every examiner, even last 1 or 2 minutes, but they would like to assess that whether you are able to do it properly or not. And therefore, if anybody wants, Nikita, how you will counsel?
Sir,
at least, always make the attempt. And suppose if you go for multiple attempts, I'm sure that will be the good improvement. And I think this is one of the benefits of this type of the case discussion. To be very frank, not only the students, but we teacher are also getting the benefits. Learning so many, I will say, points, questions from the students also. So I think it's a mutual learning for all of us. And therefore, never miss the opportunity to respond, to answer. And that attempt will help you a lot in the examination. So I think, Nikita, you can try that how you will do this exercise of counseling to the parents.
So we should explain the parents regarding the deformities and how the disease will be progressing and how episodic will be there, sir, and supportive measures should be given to the child, sir, and more of along with the
Nikita, sir is asking in the local language, how are you going to counsel the parent?
I think simple language. They don't know all these things, deformities and everything, right? And that's why I say that the counseling is important, because we have not done. That's why we are not able to at least do it properly, right? Actually, I will guide you that how we should do. Number one, always introduce yourself. It's a good thing, right? So that they come to know that exactly what position the person has. And with that, you can understand, explain whatever the possible diagnosis in your case. Even you can say, suppose if you are not understood a case of pyrexia of a origin, you can say that fever is there. We have done extensive investigations, but at present we don't have the conclusion. These are the various possibilities, and we are planning to confirm. If anything is supposed confirmed, we can have the very specific treatment like that. So here I think in this case, if we do, but whatever we have understood regarding that condition, first you should tell. Then the second, now what is your planning? That what suppose some investigations for confirmation, or even the opinion of some pediatric neurologist, or even suppose some other investigations which may not be facilities available at your place, but at other place even you can suggest. Nowadays, lot many things. Suppose liver transplantation may not be possible at my place, but I can give them the option. That which are the centers, how they are doing, what is the facility available, what can be the probable even the expenses, so that you can have, but in a patient of, I will say now, chronic liver disorder, we cannot just prescribe some supportive therapy and then send it home. On the contrary, even documentation on paper should also be done, that these are the things which you have done. So I think in this patient, how I will do, just try to give this counseling to the parents or the communication regarding the disease. We can say, I'm Dr. Baldev Prajapati. I'm general pediatrician and I'm practicing since last, suppose, 35 or 40 years. I check your child. I listen to both the parents, you in details. I went through all the records, even the old records of 7 years, illness at the age of 7 years and all the points. And later on, I examined the child in details. Some of the investigations which we have performed or performed at other places, I have checked. And probably from all the points, I come to the conclusion that your child is having some problem of neurology. What we say, the neurology, I think they understand. But fortunately in this patient, brain is not affected, but neurology is not only at the brain. We can explain that there's electricity wires are there. They are spread all over like that. These are even some of the structures related to the brain functions. They are spread all over body. And these are the wire-like structures. Probably the disease is with this disorder. Commonly we think for the polio, but which we used to see in the past. All of you know that since many years now in our country, we don't have the polio. We are very vigilant. All of us, even the doctors and the government, and probably polio is not the issue even otherwise also from the history and the examination which I have performed. Another illness which we at present see with this involvement of these peripheral nerves, what we say, that is in the form of the Guillain-Barré syndrome, what we say. That is also following some viral infection and some antibodies or some proteins develop in our body that reacts with the normal structures, and then this problem develop. This is also less possible, the way in which I have gone in the details. Unfortunately, the problem is probably quite unusual, which hardly we come across in our practice. I am trying to understand, and these are the various possibilities, very uncommon, which hardly even I have come in my practice during these many years. I'm considering, I'm thinking, and for that reason, even we would like to take the opinion of pediatric neurologists. Now we have the plenty of pediatric neurologists. And I will even give him my understanding, we'll take his suggestion, and we will plan for the further investigations which are possible at our place or even at some other place, let you know what we can do further. But what is certain, that whatever is possible with my ability, my understanding, I will do the best, maximum best for your child. And I am always with you. Whenever you have any problem or anything comes to your mind, you can contact me. And I will try to help you in all other ways. And this is the thing which I am planning. I think, and always at least put them that you are there to help them. Then they like it. And I think that's our part of duty. Suppose some even the condition which we cannot, your prognosis is bad. Then also at least you should give them some hopes, some empathy, and even some possible avenues, options, so that at least they feel that we are taking the interest for their child and they develop the good rapport with us. So I think in future also then it becomes easy for us to treat them and even to take them in the confidence. So I think like that in a case of thalassemia, nephrotic syndrome, GBS, hemolytic anemia, all these conditions, the leukemia, if you diagnose, they are going to ask us different 10, 15 common conditions or practice that how you should do the counseling. So I think every postgraduate should always exercise, and I'm sure that you'll be able to do in a better way. I think most of the things possible we have discussed. I understand that now gradually we are coming to the end of the time. So I end over here and I request to take over.
Thank you, sir. Sir, Baldev, thank you very much, sir. This is Dr. Suchitra. I'm Associate Professor.
Madam.
Yes, sir, that was a very good discussion. And about that, we are very happy to know about how you have given the ending as a counseling. Yes, because this is a government institute and our HOD is right in front of us. Dr. George sir is here. Also, our postgraduates have done well today. Divya, Nikita, and others are also watching here. And Dr. Jayalakshmi, she has also contributed a lot for this. And yes, empathy is the one thing that we consider whenever we go with the counseling. But always it is not in English that it is so comfortable to explain. That's what in local language, definitely our PGs are doing good. And also we encourage them how to counsel. And we don't make the patient go around to each and every fraternity to go. Because unless we have a group as a occupational therapy or a neurophysician and other people along with us, we know that they need to be there. But
okay, sir.
The thing that is needed at that point of.
Hello, sir. This is Dr. George, HOD, Gandhi Hospital. I think I am audible to you.
Yes, yes.
Hello. Oh,
yes.
Thing is, in our hospital we have super specialties also, because it's a general hospital. We can easily approach the neurologist, and all the investigators are also available. And even the counseling, maximum extent, they will come to the Department of Pediatrics. The counseling part is also taken care. So thank you very much, sir, for the advices which you have given. And I think the case has been excellently discussed. Thank you, sir.
I think at the end, let me appreciate Dr. Divya. She has, I would say, selected the very good case. And even she came with a good preparation. I understand to stand before even the teachers and to even the some 50, 100 people, and I understand it's even difficult for any senior person also. But the way in which you have prepared the case, even presented your points, you have kept it. Also, very good history you have taken. And even examination, very methodologically you have done. And I understand that it's a really good case and you generated good discussion also. Even your friend Nikita, she was with you to help you. And I'm sure that in the future, all other students will also come forward. Please remember as a student, unless we speak, unless we participate, probably we cannot learn much. But we can learn more and more as we participate. I understand it's always agitation to any person, and it is normal, I will say physiological, but gradually we can take it over, we can participate, and I'm sure it will be good. I should thank even the Dr. George, Madam Aparna, Dr. Suchitra, Dr. Surendranath, Dr. Yashwant Rao, and all other, even the friends. I can see many of them. Even I know Dr. Suchitra and Dr. Nirmala was also there. So it is always, I would say, great pleasure to be with the student, and I should express our gratitude for even giving this opportunity to me. Thank you very much. Thanks a lot and good night.
Thank you, sir.
Thank you.
Yes. Dr. Chandramouli, sir, you want to speak?
Yes, sir.
See, we are always missing in the last minute the diagnosis. We could have sent the blood for this genetic studies, because we have suspected Charcot marrow tooth disease. We could have sent that gene study.
Yeah.
This always happens. This always happens. Yeah.
Yes, sir. Sorry to interrupt you, sir. Actually, there was a plan for us to send, but genetic assay analysis, when we sent to NIMS, they have said that it is 28,000. See, for a patient who has come and knowing that they were counseled for how the disease progression is, they only asked us if the child is going to get well, we are going to spend. So with that confirmation, it is not possible. On academic grounds, when we asked the NIMS people to get this genetic thing done, they said they can do at the best for 18,000. So for this thing, if we keep going like this, it becomes difficult for the, hospital or it being the department also, sir. That was only concern. Apart from the finances, it is nothing, sir.
So at least you can take their number.
Yes, we have their number, sir. If somebody is coming forward to get the thing done, we can direct them, sir. No issue.
We can work out, I think, later.
Yeah.
Probably Nilofer or anybody is having a free genetic test.
No, sir. Nilofer doesn't have. Even all the Nilofer are here.
We don't have any free genetic testing. So there are many rare cases which are identified and diagnosed clinically, but it stops at exome sequencing genetic testing, because it has to be paid and nobody does it for free.
But the genetic this thing is there, no, in government institute.
We don't
do for free, sir. You have to pay them.
Even in the government,
which the patient cannot
is there. Institute of Genetics is there, no? They also don't
There
do.
also it has to be paid, sir.
Okay.
You have to
Because
pay money, and because they are poor, they don't afford so much of money. That's the problem.
no, that is a very,
They
that's
also have
very
to send to
cynical
third
because
party.
they also lost, we also lost.
Let
As a faculty, we have
Yashwant
lost
come
the
forward.
diagnosis. As a patient, they have lost the future
Yashwant will
plan.
come forward with IAP, sir. IAP will do.
Okay, sir.
Yashwant,
But it
IAP
was an
sir
excellent
will know.
presentation, and I especially
Yeah,
thank
yeah.
all the participants. Dr. Baldev was excellent in his approach. Thank you, sir.
Thank you. Thank you, Baldev Prajapati sir and
I
Judge
want
sir
to tell
for your
one minute.
guidance.
1 minute I want to tell.
Yeah, Aparna madam, please.
So we had excellent case discussion, excellent presentation by Divya and Dr. George also, under the guidance of Suchitra and Dr. Jayalakshmi. So I can thank IAPTCB for giving me this opportunity.
PATS.
Thank you. Thank you. PATS, I think.
It is PATS, ma'am.
PATS. I thank PATS for giving me this opportunity.
Yes. Yeah.
Thank you, Baldev sir. Baldev sir, Aparna madam, George sir, Suchitra, Jayalakshmi, and we should not forget our PGs. They have presented well systematically, as sir has said. It should stimulate all the other PGs to participate and continue in a big way. Every third week, we'll continue to have a PG teaching program. We have done CNS case. Next time, we will request the other colleges to join us. This endeavor will be a continuous one because we will never miss the PG teaching program. Thank you, one and all.
Thank you. Thank you.
Thank you, sir. Thank you.
Okay, thank you, Baldev sir, and thank you, Yashwant.
Dr.
Vice
Venkatramana
Chairman,
has added a few more points.
Thank you, sir.
Thank you all. Thanks for joining.
Vaidhyam Chakravarti, neurologist.
Thanks.
Thank you, sir. Thank you.
Thank you. Good night. Good night.
Vote of thanks by treasurer.
Okay, ma'am. Thank you.
Dr.
Thank you, sir.
Vaidhyam. Vote of thanks.
Chakravarti.
Are you there? If he's not there, I would ask any of the EP
Vamshi
members.
Chapo.
Dr. Suchitra, vote of thanks.
At the end of the session, I thank our President, Dr. Yashwant sir, Secretary, Dr. Vamshi Kondle sir, Treasurer, Dr. Vaidhyam Chakravarti sir, and all the EPs. Special thanks to our the main mentors like George sir, Dr. George sir, HOD Pediatrics, Dr. Aparna madam, who is again expert in this. Above all, Dr. Baldev Prajapati sir, we are really thankful to you for your valuable suggestions and guiding us. Also, a special thanks to Dr. Jayalakshmi madam, who was there throughout the presentation and supporting the PGs. Thanks to all the postgraduates, especially Divya, Nikita, and all the other postgraduates who have attended this. Also, the pediatricians around IAP, PATS for participating, and we look forward for the similar participation in coming programs. Thank you, one and all.
Ashraf sir has joined from Khammam. Archana Swami sir has joined. Then other
Lakshman Swami sir, yes, he has given good inputs also, sir. We are thankful to you for your book also, sir. Our PGs also follow that.
Thank you,
There are few clinches in that. We definitely go ahead. We are thankful to see you now. Our UGs and PGs. For PGs, it is good, sir. For UGs, still there are few things. We still go with Hutchinson and then your book, sir. Thank you very much.
Thank you, Ms. Mona.
Thank you, sir.
Thank you so much.
Thank you. Good night.
Thank you.
Suresh Thomas sir, Prasad sir. Thank you.
Okay, ma. Thank you. Thank you, one and all.
Thank you, sir.
Thank you.
Thank you.
Thank you.
Good night.
Thank you.
Good night. Good night.
Chandrakiran, thank you. Satish.
End చేసేయమంటారా సార్ సెషన్
చేసేయమ్మా